all, welcome. I would like to welcome Dr. James Bussell, who has kindly agreed to uh, talk to us, to the pediatric hematology oncology community of India, on a very important topic of immune thrombocytopenia in children. Um, his introduction, I think all of us know Dr. Bussell from all his publications and the amount of work that he has done in the field of immune thrombocytopenia. But I would still like to formally welcome Sir and introduce him to our audience. Dr. Bussell is a board certified pediatric and pediatric hematology oncology specialist. Particularly, his interest has been in immune thrombocytopenia. Throughout his distinguished career, he has treated rare hematological conditions both in children and adults with a unique and an extensive expertise in immune thrombocytopenia, other thrombocytopenias like Evans syndrome and NAIT. He was the first physician in United States to use IVIG as a treatment option for ITP, which helped to pave the way for its FDA approval. And now it is the standard of care for all of our newly diagnosed ITP patients. He even helped to pave the way for its use for the standard of care for neonatal alloimmune thrombocytopenia affected pregnancies. So he trained extensively in the United States, and then he attained a fellowship in pediatric hemonc at the New York Hospital Cornell University Medical Center and Memorial Sloan Kettering Cancer Center, where he became the chief fellow. Through his training in pediatrics, Dr. Bussell attained a lot of expertise in managing the hematological conditions. And currently, he serves as a professor of pediatrics emeritus, a professor of pediatrics in medicine emeritus, and a professor emeritus of pediatrics in obstetrics and gynecology at the Weill Medical College of Cornell University. He's affiliated with the New York Presbyterian Hospital and founded and served for many years as director of the Platelet Disorders Program. Prior to his current appointments, Dr. Bussell served as a hematologist at the New York Presbyterian Hospital, Memorial Hospital for Cancer and Allied Diseases, and Lenox Hill Hospital. Among his many achievements, Dr. Bussell has authored over 300 peer-reviewed research publications, authored over 40 book chapters, and contributed to over 140 medical reviews, including authoring 9 articles in NEJM. He's a reviewer of medical journals such as NEJM, Blood, PBC, and British Journal of Hematology, for which he is an associate editor. Dr. Bussell has acted as a primary investigator and co-investigator for many research trials on immune thrombocytopenia especially. I think, his CV is really extensive, and it is such a big honor for all of us to have him here to speak on a topic for which he has, dedicated his life and really put forward the way we manage immune thrombocytopenia in children at the moment. So over to you, Dr. Bussell.
Thank you very kindly for that very, very gracious introduction. I would say that I had the great pleasure of attending the pediatric hematology meeting, though if there's more than one type, I'm not sure which it is, in 2014. And I've had considerable interactions with hematologists from India. So I'm planning this talk for a sophisticated audience because I know how smart you all are and how you know lots of things. What I'm going to do, if it's acceptable, is when I present 3 different cases for discussion, I'll pause after each one and allow for questions then, if that's all right with the organizers. Okay.
Yes, please. Yes.
Can you see my screen?
Yes, we can see the screen.
And I know I have to get into presenter mode, so one more second. Okay. I do consult for a number of pharmaceutical companies you see there, and I will at least briefly mention medications that are not licensed for ITP, even surprisingly including rituximab. Rilzabrutinib's a BTK inhibitor. Rozimab, or also called rozanolixizumab, and efgartigimod are FcRn inhibitors. And I suspect you all know about eculizumab, which is a C5 inhibitor. Again, I think you know that ITP we've learned, is a combination of increased platelet destruction and suboptimal platelet production. Not all patients have detectable antiplatelet antibodies, and there's a lot of debate about why. There have been abnormalities of regulatory T cells. Recent studies showed that some of the more difficult patients may have cytotoxic T cell clones. Many abnormalities of immunity have been demonstrated, though there's not a perfectly simple theme. But what I would like to emphasize is that while we can talk about ITP patients as a group, if you have a patient in front of you, it's often very hard to know exactly what's going on in that patient and what to do about testing, when to do certain testing, and what special tests are or are not available remains a great mystery, unfortunately, still. This is from the consensus document that usually comes out in parallel to the ASH guidelines and is more of a high-level opinion piece, whereas the ASH guidelines, as you may know, are a more formal analysis. And the bottom line here is that really the only lab test that everybody agrees on for all patients is the CBC and looking at the smear. And there's a list of many others, and I will come back to that later. And there are lots of things we don't know. We know, for example, that most children will enter remission. If you say at a year, it seems to be give or take 80%. It obviously varies some study to study, location to location. If you go longer, it's more children. If you want to know at 3 months, it's fewer children. So, but we know, fortunately, that most do. We don't exactly know why certain children develop ITP. The genomic studies are still in their infancy as far as being very specific about what happens, and thus far are only identified in a small minority of ITP patients if they have, let's call it simple or just ITP, whereas in Evans syndrome, you can identify things in a little over 50%. Which biomarkers are important probably varies a lot from patient to patient. Can we predict which patients will respond to which treatments? Again, very limited at best. I'm sure that with such a sophisticated audience, many of you know that fatigue and depression occur, even in children, might be manifest in some irritability, but how we manage that and why it happens is still something that's remarkably unclear. The European Hematology Association is preparing some new guidelines, and one of the questions for pediatrics ITP is, when is genomic testing appropriate? And it seems that's at the 6 to 12 month mark, and not usually right in the beginning, unless there's something that makes you think it's appropriate. We don't really know a good way that's widely available to evaluate risk of bleeding other than bleeding begets more bleeding. And a lot of the management is really an art, because many of the tests are very useful in, let's say, 1% of the patients, not so commonly useful in all patients. So that's why it's been hard to define what to measure when. We also know that only about 1 in 200 children, give or take, would develop an ICH, given that that's in the setting of many patients receiving treatments. And you know that there's a lot of treatments available and more on the way, and we'll talk about those. And what I'm hoping to do is to look at some example cases, to talk about the Tiki trial, which randomized IVIG versus no treatment, to talk a little about some of the types of secondary ITP, to talk about newer treatments like avatrombopag, efgartigimod, fostamatinib, and I don't think I need to talk to this audience about dapsone because you may know more about it than I do. And then if we have time at the end, do what I'm calling going off the reservation and talking about fetal and neonatal immune thrombocytopenia. So first example would be, and I should say these three examples are borrowed with slight modifications from an article in Blood that Michelle Lambert and Rachel Grace did. A 3-year-old female with 1 day of petechiae had a URI recently, generally healthy, no medications and no recent vaccinations, no family history of thrombocytopenia or autoimmunity, and is generally well appearing, diffuse petechiae, no signs of systemic lymphoid disease, and blood counts are normal with the exception of a very low platelet count and large platelets. So I don't think it would be too surprising to you to think that most of the time that's going to be a girl with typical de novo ITP. In the paper that Doctors Lambert and Grace have, and I think it's from 2022 now, they cover and make a figure here that's in the paper about how to look at different patients and how to evaluate different features. I think I'm not going to go over this at length. If you have a child who has anemia, but they're microcytic, that usually, at least for me, gives me a degree of comfort because it suggests it's iron deficiency or a thalassemia trait. I don't know about your blood count machines. As they've gotten more sophisticated, things like platelet clumping will often get called out by the autoanalyzer, and that makes life easier. But looking at the smear is important. And if you have a girl like this one with a count that's supposedly 3,000, if they have clumping, they may, as you all know, have many fields with no platelets and then just have a big group of them all together in one spot. So important to not only look at the smear, but look over large parts of it. Inherited platelet disorders, when I've asked Carlo Baldwini, who I think of as the person in the field, he said the most common way you pick it up is large platelets. And I'm not really going to talk about the other features unless there's a particular question. So this is when I'll pause and take questions if somebody wants to ask them. And I would encourage you to just speak up. All right, I'm going to go on and we can come back to this case if you were feeling shy or whatever, but wanted to ask something. So different case with a family history. 12-year-old male arrives. He had a complete blood count the year before because of maternal family member with ITP, and it had a count of 90,000. His mother has a history of heavy menses and easy bruising. During her pregnancy, she was not allowed to have an epidural. I don't know, in all honesty, how often an epidural is used in India, but in our setting, most women would at least want to have one, and you need to have a platelet count above 70 or 80,000. So it's a way of saying that her platelets were low enough in pregnancy that that wouldn't happen. That didn't happen. This patient's recent, the repeat count is 82, and his other blood counts and physical examination are normal, and the peripheral blood film looks remarkably normal. So I think this is probably unreadable, again, borrowed from their paper, but the point is, if you have normal thrombocytic, meaning the platelets look normal, they're not large, there are a series of conditions that can cause this. And in this case, we're thinking about RUNX1, or familial platelet disorder with predisposition to AML. It's one of the reasons, and I don't know how this works for you, but again, in my practice, if a pediatrician calls me and says, oh, they did a routine count on a patient and it came back at 80,000, instead of saying, just keep following it and let me know if it gets, let's say, below 50, would often want to evaluate them at least once, because if there is significant platelet dysfunction, that may be a clue to some of these other conditions, also including ETV6, that may predispose to a malignant disorder, and especially if there's a family history. Again, I'm willing to stop and take questions if anybody has one.
So, Dr. Basil, how often do you see all these conditions like ETV6 related thrombocytopenia or RUNX1 related disorders? Because they are rare and we definitely miss them when we are evaluating children with ITP. But how often do you identify these conditions?
That's a great question. In Italy, they seem to have more inherited thrombocytopenias of all type, including some of the more common ones that may have macrothrombocytopenia like May-Hegelen, or conversely, microthrombocytopenia like Wiskott-Aldrich. So those are probably more common than the ones on this slide. And I think in their studies, population-based, they think that for every 10 ITPs, there's one inherited platelet disorder. Now, I'm not sure if I have it on the next slide. Yeah, there's more than 33 different forms of inherited thrombocytopenia. It seems like somebody's describing a new one all the time. And I think, as you just said, they often get missed because the individual conditions are very uncommon. I think in addition to any consideration of bleeding, and in most cases, that involves for a risk of bleeding with a procedure or possibly in pregnancy for delivery, the reasons to identify them are for the associated other features that they have. So you're absolutely correct that seeing any one of these conditions is very, very rare. Seeing an inherited thrombocytopenia is probably a little more common than we all think it is. And I brought this case up because I think it's important to at least consider these. Things that might make you think it is one are, like we said, if the platelets on smear are quite large, if there are any syndromic features that suggest one of them, if there's a family history. And for Wiskott-Aldrich, which we see in boys relatively commonly, if there's any history of infection or things like that. My experience with ITP is that it's very, very, very rare to have a case of ITP in a first degree relative. Like to have two siblings with ITP, I've maybe only seen two families like that in my whole career. So whenever you have anything that looks at all close in family linkage, then I think you should, put your antennae up and say, hey, this may be something different. And last, in terms of cases, 16-year-old female with a history of anemia at age 3, who's referred with new diagnosis of thrombocytopenia, primarily because of petechiae and nosebleeds. She's been seen elsewhere and her family doesn't recall the diagnosis. She did take a medication for several months. She has a palpable spleen. She has isolated thrombocytopenia with a count less than 10,000. She has normal hemoglobin, reticulocyte count, and bilirubin, but her direct antiglobulin test is positive. Initially, because she was not bleeding and it wasn't clear what was going on, she was observed. But after she developed more bleeding, she was treated with prednisone for 5 days and her platelets responded, but the thrombocytopenia recurred. Now, I suspect that this is something you do see and might be somebody with anemia and a retic count. My experience is that in most of the patients with Evans syndrome, they don't have anemia and thrombocytopenia in clinical conditions, clinically significant ways at the same time. We speculated in a publication that we did about a case where the boy had thrombocytopenia and was getting treatment for it. And then all of a sudden he developed autoimmune hemolytic anemia. And one of the first things that happened was that his platelets went to 420,000. Now, you may remember that there was an agent for treatment that's largely out of use called anti-D. And the idea there was you would sacrifice a few red cells to clog up the destruction network and have the platelets go up as a result. So I think it's like giving yourself anti-D when you develop the autoimmune hemolytic anemia, and that's why you typically don't see them together. But at times you do, either with intravascular hemolysis or intravascular thrombocytolysis, or if one of the features of one or the other or both is impaired production. There was a nice study from Necker in Paris with Dr. Rieux-Lecault. I might be mispronouncing the name, and Alain Fischer was on that. And they identified, I think, 60% or so of children with Evans syndrome having a monogenic disorder. And a group in the United States led by Jenny Despotovic confirmed that. And it's a wide variety of different genes that can be involved. And what's confusing is that a lot of the genes that are involved, on the one hand, may be ones that you think of as causing immune deficiency, but in reality, these can be gain-of-function mutations, which is why they have autoimmunity. That's not the only reason, but that can happen considerably. The pediatric hematology group in France, led by Nathalie Alagidi, has identified that many of these patients may have immune dysregulation or other features prior to their cytopenias, or more commonly, will have just their cytopenias and then later develop other features of autoimmune disease like arthritis, or if it's lupus, even kidney problems. So it's very important to keep following these children on a regular basis. Initially, it appeared that rituximab was very effective in that setting, but the group at CHOP in Pennsylvania, David Tichy, and the one at the NIH, led by Kennedy Rao, identified that some of these children developed lifelong hypogammaglobulinemia afterwards, meaning that they would require IVIG or subcutaneous IG for life. So currently, the preferred treatments are mycophenolate mofetil or sirolimus, although you may have to start with steroids to get the count up more quickly. In children, long-term studies of natural history led by Winifred Wang at St. Jude showed that avoiding splenectomy is preferable because they not only does it not work, but it gives them an increased risk of sepsis because they may also have immune dysregulation. In the adults, Mark Michel at Mark Michel and the group at Henri Mondor and the French adult team group thinks it's splenectomy is reasonable for adults with Evans, which seems to be a different type of disease. So I'm ready to stop and take questions about Evans or other cases. We'll come back to some of the other types of secondary ITP.
I have a question, if I may.
Please.
I'm Vandana. I'm a pediatric hematologist at St. John's Medical College in Bangalore. I just had a question about the inherited thrombocytopenias, the second case that you presented. I have a very similar patient, a 14-year-old who's had thrombocytopenia for a very long time. Initially thought of as ITP, treated with many drugs, but didn't respond. So we did a genetic study on her, and she has an NRAS mutation. So I was wondering whether you had any patients in the similar sort of cohort. I know you talked about the other mutations, but I didn't see anything on NRAS. So did you, any pointers as to how to manage this patient?
That's a great question. And to be honest, I don't have a good answer. I will tell you a couple of things that I think you already know, but in case other people don't, that type of mutation can be associated with JMML, or at least mutations in NRAS, and or it used to be thought that some forms of ALPS, had autoimmune lymphoproliferative syndrome, had mutations in NRAS. There is going to be an article coming out in the British Journal of Heme in a new category of articles that I actually helped develop called Nutshells, that is specifically about RASopathies, either KRAS or NRAS. So that may be helpful. And that's the best I can do. I don't really have any personal experience and no real knowledge on this. Okay?
Thank you very much. Thank you.
But look out for the British Journal of Heme article. Ideally, it would be online in 1 to 2 months. And the first author would be Kate Sullivan.
Sure. I just wondered whether you thought sirolimus might be useful because that is one agent that I really haven't tried on this patient.
Sure. And by the way, you reminded me, I meant to say, we published an article on refractory ITP in Blood in February 20, and Michelle and Rachel kind of imitated that article a little in their publication in Blood in 2022. And I'm only taking the liberty of saying that because they told me that. But the point I wanted to make that I think very important is the more you have a patient who has refractory, quote, ITP, the more likely it is that it's not really ITP. And it could be in a marrow failure state, could be myelodysplasia, could be an inherited thrombocytopenia. But if you have somebody who's refractory and not responding to anything, then you very much should pursue all those options. And one thing that I know you all know that's confusing is if the only thing they respond to is a thrombopoietic agent, that doesn't exclude that you have another type of thrombocytopenia. That doesn't, quote, confirm, unquote, that it's ITP. I suspect you may have seen previous articles on iWish. The two main articles came out back to back in the American Journal of Hematology, I think in 2021. And this is newer data from a repeat survey that has not yet been published, but has been presented. And I mentioned before that we really don't know. We have a lot of phenomenology about this, meaning we can tell you what people with it do or don't do or so on, but we don't really have much mechanistic understanding. And for example, at least in our world, but I bet in your world too, if you have a teenager who complains a lot of fatigue, the first thing I would ask is, how late at night do you stay up texting with your friends? Because that's probably far more common than anything related to ITP. But again, it is perfectly clear that, like anemia, having ITP can be associated with intrinsic fatigue and depression for that matter. And certainly there are medical causes, and there's a list on this slide. How to sort this all out is very difficult. And I don't know if you ever see patients with chronic fatigue syndrome having nothing to do with ITP. That's a very difficult history to obtain. It takes a very long time, and you end up having to do, at least we do, quite a lot of testing to rule out obvious causes. I think the ones you could think about the most obviously, but again, you would know in your practices what's most likely, would be hypothyroidism and anemia and iron deficiency particularly, but certainly lots of other things. And talking about other testing, in an adolescent female, especially looking for antiphospholipid antibodies, thyroid-related things, quantitative immunoglobulins, and especially an ANA can be very, very helpful. And there have been a lot of studies recently about patients who have a positive ANA and what does that mean. And studies from France and one that's just coming out in Pediatric Blood and Cancer suggest that these patients, if they have an ANA of, let's say, one in our setting, 1 to 40 is the lowest you'll detect as positive. So 1 to 40 and 1 to 80 are relatively common, but certainly 1 to 160 and more suggests that these patients are more likely to have chronic ITP and more likely to develop other problems, antiphospholipid, even lupus as examples. And what's important, like we said with other patients, is that these manifestations can take years to develop. And even the people who have low titer ANAs, it's worth following them yearly to see if they increase or not. I guess the only, what I would say, good thing about this, if I can use that word very loosely, is that in all single-arm studies, it appears that hydroxychloroquine is an optimal treatment in these patients, whether or not you have to add another treatment as well. So studies have suggested that, and that at least potentially makes things seem to be better and may delay or eliminate development of some of these other manifestations. Now, there's a lot of different types of secondary ITP that I'm sure you're aware of. I've always paid particular attention to common variable immunodeficiency, and that would be something because it's relatively common, and it has specific management associated with it. Actually, paradoxically, if you're intrinsically hypogammaglobulinemic, the best treatment for that to cure it and make it go away is to give rituximab. Now, the good part is it not only will bring up the count, but often will be curative. But the bad part is that that will require you to give the person immunoglobulin, quote, for life. I don't know how H. pylori works in your setting. In our setting, it can be there, but doesn't seem to be related to the ITP. In Japan, it's very commonly related, and that's a test you would do in all patients who present with ITP, though I think pediatric data is much weaker than adult data. Also, you would do testing in Italy, but why it's so different is not completely clear. And fortunately, it appears that COVID vaccine-related ITP is much more common in adults than children. And even when it does occur, it seems to be transient in the great majority of cases. Now, to talk about the Tiki trial, 200 children were randomized over 6 years in the Netherlands, from 2009 to 2015. They either gave them no treatment or they gave them IVIG 800 milligrams per kilogram as a single dose. This would be within the first week after diagnosis, and children could not have any other treatment, and then they were followed. So what was interesting was, and by the way, in addition to being maybe the largest randomized trial of pediatric ITP that included no treatment, the other feature of this was that they allowed children who had grade 3 bleeding to enter the study. Previously, grade 3 bleeding would have been an indication for treatment, and therefore these children would not have been allowed on trial. What happened in the no treatment arm? 8 children were hospitalized for bleeding, 7 of whom had had grade 3 bleeding at diagnosis, and the great majority of whom were hospitalized in the first month. 1 had an intracranial hemorrhage. These children were all treated, and that patient supposedly has recovered well and is normal, but as you can imagine, that's very difficult to say, especially in the short run. For the 100 who received IVIG, they had 5 who were admitted for reactions, 4 with headache and 1 allergic, and 1 was hospitalized for bleeding. Now, it's important that no pre-meds were given for the IV gamma globulin. I don't know what you do, but I believe, and there's now a small study from Manny Carcao of sick kids confirming that using paracetamol and antihistamine and steroids, especially steroids, will help minimize headaches. Many people also believe that you should give additional fluid. That remains to be seen. The results of the study, as far as the goal, which was, did you prevent chronic ITP, showed that you had a significantly earlier time of remission, meaning when your count became normal and stayed normal after that, at 1 week, 4 weeks, and 12 weeks. And people tended to be in remission more at 6 months as well, but there was no difference at 12 months. I apologize for the typo at the end of the slide. There were 10 patients at 12 months with chronic ITP who had received IVIG and 12 who had received no treatment. So some clear benefit, some clear absence of benefit. And my take on this was that if you had grade 3 bleeding, they would be treated. A further update on this has been to only include what is now being called grade 3B bleeding. So if you had nosebleeds of 5 minutes, that would be grade 3. But if they were more than 15 minutes, that would be grade 3B. But further studies would need to clarify this, but I think this is a landmark study. And also, there's always a question of, can steroids be used without doing a bone marrow? That may not be a question to the people on the call anymore, but I would just remind you that in 1965 to 1990, when patients with apparent ITP would undergo bone marrows, at sick kids, they retrospectively looked at about 450 cases. 300 were typical ITP with normal white counts and red counts. And of those 300, the bone marrow identified 1 case of aplastic anemia. Of the 150 or so cases that had minor abnormalities with the white count a little low or a little high, but you said, oh, there was a preceding viral infection, and or if the hemoglobin was low and you said, oh, this child had heavy menses or a lot of nosebleeds, 10% of cases had other diagnoses, including 7 with leukemia and 7 with aplastic anemia. But the flip side, there used to be 2 pediatric leukemia study groups, one called CCG and one called POG, Pediatric Oncology Group. They've now merged to be one, but the POG studies of leukemia with hundreds of children diagnosed with leukemia identified not 1 case that had just thrombocytopenia in a normal exam. Closest I came was in a girl with Down syndrome who had just thrombocytopenia and normal hemoglobin, normal white count, but had marked splenomegaly. So current guidelines suggest that at least about 80% of children with uncomplicated ITP could be observed. Now, what are the things that would make you want to seriously consider treatment? For me, wet purpura, blood blisters in the mouth. If there's significant bleeding, especially hematuria. The general idea is to ignore the platelet count, even if it's very low, if there is nothing else going on. But I worry that there's less reserve there. But a general consensus is ignore the platelet count. Lifestyle could matter. Sports, travel, or activities that are physical might require better platelet counts. If there's a comorbidity, it's unusual in children, but if you're on an antiplatelet or an anticoagulant, sometimes parental or patient anxiety, and again, I'm sure you're familiar with this, is huge, and it's just probably better to do low-grade treatment, perhaps a very short course of steroids for a week or something like that. I'm not, by the way, a big fan of dexamethasone in pediatrics, though I am in the adults. And finally, fatigue, irritability, depression, if there's an important reduced quality of life, I think that's a reason to treat. But these are all obviously individual decisions, and they take a lot of time to make because you need to discuss them carefully with the family and the patient if they're old enough. Flip side, though, I think it's important not to undertreat the ones who need treatment. We published a study in Blood in 2009 of 40 cases of intracranial hemorrhage in pediatric ITP. A quarter of the patients presented their ITP with, an intracranial hemorrhage, sometimes or often related to head trauma. Another 10 or so had their intracranial hemorrhage in the first month, another quarter within the first, say, 3 months, but more than a little over a quarter occurred in children with chronic ITP. So, and the other thing I would point out is that it seems clear, though the data for this is not strong, that a child who is going to really be at risk for bleeding may not respond to just steroids or just IVIG or even both of them together. So if somebody needs to be treated for bleeding, giving them, quote, the correct treatment is not a sufficient way to do it. You need to monitor, and you may need to give them additional treatment. And that's why in a COVID vaccine thrombocytopenia article we published in Blood in 2021, we added vincristine because that can be very effective in short-term treatment if standard treatment's not working. I can stop and take questions then, but I'm getting toward the end, I think.
Thank you, Dr. Basil. We have a few questions in the chat box, if we can take it now.
Yeah, I'm looking at them.
Actually, like the first question, what are the pointers to guide for genetic testing in kids with thrombocytopenia without any physical stigmata?
I think that the EHA guidelines, European Hematology Association, are going to suggest that any child who's had ITP for 6 months, it's not going away, and they have significant disease, meaning I don't know that you need to do genetic testing if a child has a platelet count, let's say, of 50,000 on no treatment, but a child with significant clinically important ITP at 6 months, I think that will be the recommendation. I don't think the yield will be very high, but it's certainly important to do.
Okay, thank you. We'll move to the next question. Would genetic workup for monogenic disorder be needed, even if an underlying autoimmune condition like SLE is identified, especially in Evans syndrome? And if you have any specific age cutoff to do this genetic workup?
I think that's a great question. Again, I'm just giving you my opinion here, and I'm emphasizing that because I don't think there's a lot of data to say one way or the other. I don't think there is a specific age cutoff. And I think the question is, would you, for example, alter your management if you knew specifically what the genetic defect is? Currently, I would say often that is the case. If you found a CTLA4 mutation or an LRBA mutation, you might give CTLA4 antibody, which sort of restores normal function. You might do that. And the same for some of the other findings. So I guess I would say, if you're going to do it, you should do it in pretty much any case, because it might alter what you do. Will you always find something? Definitely not. Will it always alter management? Definitely not. So I think if it's a resource limited question, you have to make up, I think, your own mind. In Evans syndrome, it seems to be the clearest that you have the highest likelihood of identifying a genetic disorder.
Great. So the next question is a continuation of the discussion. Like as you mentioned, the yield of genetic testing in ITP is very less, but more often we get these kind of reports like heterozygous mutation of uncertain significance.
Right.
Here, how to
that having a variant of unknown or uncertain significance bedevils everybody in any field. I think the most important thing to think about is when the lab tells you that, because usually it's something that comes from the lab, they're not always fully up to date. So you want to go into the literature and the online websites that try to keep up to date and make sure that it's really a variant of unknown significance and that it hasn't been reported before in another case of, let's say, ITP, even if it was not called, even if it's being called a variant of unknown significance. I mean, to prove it is extremely difficult, as you may know, and is not going to be possible in most cases. But if you find other cases with it, then I think you would have to take it seriously. I think there are programs to estimate whether it's important mutation or not based on where it is in the gene. And those are getting better, but they're still so far from perfect, and different ones will give you different results. So it's probably worth considering them, but again, I'm not sure how helpful they would be. And I can see two more questions. One is about the natural history of chronic ITP. Is it the same as Evans if you rule out, for example, genetic causes or ALPS? I think Evans has a worse history, and I think if you have a true isolated chronic ITP, even after a year or 2 or 3, they still may get better. And the long-term TPO studies, for example, show a quarter of patients coming off after a year or 2 of treatment. And you could say, well, that's because of the treatment, but I don't think we know that. But I think it's better natural history if it's, quote, chronic ITP. There's a question about a role of bortezomib in refractory ITP. And I think people have not loved bortezomib in particular, but there are studies, for example, from Walid Ghanima on using daratumumab, which is another plasma cell agent, and using dexamethasone even is an anti-plasma cell agent. So I think those would be better if you had them. The idea that attacking, let's say, B cells with rituximab is not enough is a good point. Another way to look at that has been to use FcRn inhibitors when you can lower the IgG level 60 to 80%. And I'll try to come back to that. I commented on H. pylori already. I don't know in your setting. In my setting, looking for it and treating it is not very useful, and there's limited pediatric data.
There are 2 more questions. Like one is a child. Yeah. Yes.
One of the question about a heterozygous mutation in an autosomal that's in an autosomal that is known to cause disease when it's homozygous because it's an autosomal recessive mutation is, I think, a very difficult thing to answer. If it seems like the patient matches that, then there may be a question of expression. You might have to go to RNA-seq to find out if the other gene that's supposedly normal really is being expressed. I think you would, in principle, consider them as idiopathic, but again, it depends about how much workup you can do. If a child with ALL on maintenance develops ITP, the first question is, how do you know that it's ITP as opposed to, let's say, drug-induced thrombocytopenia or some kind of marrow failure state? I would think you'd have to do a marrow. If you could, you would want to measure TPO levels. And if the patient responds to, let's say, IVIG, then and you really do think it's ITP, then you'd probably you might have to treat like ITP. The questionnaire very astutely asks about using whether you could safely use thrombopoietin. I guess that would be a little worrisome. It doesn't seem to predispose to cause problems in ALL, but I would say if you could use something else, it might be better. And it might be that if you change the maintenance, like if maintenance is 6-MP and methotrexate, if you could alter those drugs, then that might work also. But I don't think we know exactly about that. If it's okay, I'm gonna try to wrap up. I apologize. I switched the slide trying to get rid of the chat. So I think you know a lot about the medicines. I would point out that fostamatinib is not to be used in children, at least currently, because it's thought that it will interfere with cartilage and growth. People have tried to do a study in teenagers, late teenagers, but I'm not sure that that's really gotten off the ground. Dapsone seems to be a perfectly useful agent, and we recently accepted an article in the British Journal of Heme that I think was in adults. I don't remember perfectly. I might be wrong. And I'm going to try to tell you about some of these other agents briefly to finish on time. This is data with rituximab, and the point here is that adolescent females, this is from Journal of Pediatrics published in 2017, Joe Ovid and myself. And what you see is that adolescent females are the ones most likely to be cured. We've seen this in adult women also. So I would say if you had an adolescent female, that would be one to definitely think about doing treatment with Rituxan. And that's one of the few individual characteristics to consider. And we use it with 3 cycles of dexamethasone. I think you know it'll block response to vaccines. That's important for COVID and flu. Generally, it's pretty safe. Exactly what dose to use is not clear. If you use it with Dex, you need to monitor IgG levels. There's a lot of data, as I suspect you know, in pediatric patients with the TPO agents. There's just emerging some data with avatrombopag from China. There is a study ongoing in the US that I think is just about finished enrollment, but has not finished the treatment phase and therefore won't be published right away. The one thing I would say with eltrombopag and romoplastin or Nplate and I was going to say Promacta, but you have a different name for it that I forgot. With Nplate, there's a lot of long-term data. with eltrombopag, there's very good initial data, but there's not a lot of good data long-term in children. I think that's probably not important given the long-term data in adults and the long-term data with Nplate, but I'm just pointing it out. You may know that Nplate's a shot once a week. Eltrombopag is a pill or a suspension once daily, but it has to be kept away from especially cations like calcium. So that would be dairy products for hours before and after its use. There's been some recent study in adults combining it with dexamethasone where that seems to have a little better response. This is long-term Nplate data just showing you that this is out to almost 5 years. And this is our data on bone marrow showing you that only one child up here, the very top one in the yellow, even got as far as grade 2 fibrosis. So it does not look like any marrow fibrosis should be a concern. And what's different about the use of TPO agents? There's probably a lower risk of thrombosis and of myelodysplastic syndrome. Very young children may need higher doses per kilo. We've used up to 6 per kilo of eltrombopag in a very small 1 or 2 year old girl, and the same to a lesser extent with Nplate. This is taken from the ASH guidelines, and I think it points out the need to talk to patients and really factor in many, many different things in deciding what treatment to use, whether to give treatment, and so on. The idea is at all possible to minimize the use of steroids and to use prednisone over dexamethasone in children. I think this is TPO rather than rituximab, TPO rather than splenectomy, rituximab rather than splenectomy. Certainly in children, avoiding splenectomy seems to be optimal, but I think splenectomy has a worse long-term outcome in children because you have more years to develop sepsis or a thrombotic problem. Again, I would use rituximab in a teenager, and I'm going to try to wrap up. We talked about these patients. If it's a 15-year-old girl and you wanted to treat her and she's been vaccinated or you vaccinate her, try rituximab. If you have somebody who's very active and the steroids make them even more crazy, ideally you'd give them an oral agent, so they should be big enough to take avatrombopag, but again, very limited data in kids. And if you have somebody, especially with blood in the urine, which has been identified in 2 studies, one ours, but one from Japan, as a sign of potential impending intracranial hemorrhage, you want to give more treatment rather than less. And even though you might say, oh, if you give, let's say, Nplate, that's not going to work for a while. Yes, but especially when you're slowing down platelet destruction, it may work a little faster, and it may mean that you won't be still having to worry 5 or 6 days from now. Avatrombopag works very well, seems to be a very good agent, doesn't have dietary restrictions, doesn't have liver test abnormalities. Been a little bit of a question in adults about thrombosis, but switching studies have shown that if you're on Nplate or eltrombopag, you can switch to avatrombopag and often have good effects. If you have somebody truly refractory, we and others think your combination should include thrombopoietic agent and something else. The French are very happy with a TPO agent and azathioprine. That's been done in adults, but probably good in kids. But if you said I prefer to use mycophenolate or something else, no reason not to. FcRn recycles IgG. So it comes in through plasma or on an antibody-coated platelet, goes into an acidified endosome. Because of the acid environment, the IgG in the endosome binds FcRn, which is on the outside of the endosome, which then carries it to the surface and then releases it, because in normal pH, FcRn does not have avidity for IgG. Incidentally, FcRn also recycles albumin and also transports IgG across the placenta. And here you see a better view of here. This is IgG coming in for pinocytosis. We believe the same thing happens if you have an antibody-coated platelet coming in. This is adult data. This is the phase 2 rozanolixizumab data. And you could see at the highest dose, you not only get a really good platelet count, but you get it within 4 days. And I believe that a much higher amount of the IVIG effect is due to its saturating FcRn than we had anticipated. And you see here that the IgG levels drop, and here in the highest dose, it's down about 60% after 1 week. This is data I don't have time to discuss, but this is showing that in 7 of 13 patients with very, very bad Rh disease, hemolytic disease of the fetus and newborn, an FcRn inhibitor, nipocalimab, allowed the next pregnancy to just sail through without it needing intrauterine or postnatal transfusions at all. And that's been being reviewed. Talked about fostamatinib, not really for kids. BTK inhibitors have not been used in kids. You may know that ibrutinib, which was the first one and which is very good for B-cell malignancies, interferes with collagen interaction with platelets and therefore led to bleeding. Rilzabrutinib was engineered not to have this, and this article was published in the New England Journal a year or 2 ago with David Cooter as first author. There's no pediatric data yet, but there is an ongoing phase 3 study, and that's very good. This agent inhibits C1s and is a complement inhibitor. You may know there's a proliferation of complement inhibitors, especially C3 or C3b inhibitors. Probably those will work very well in ITP, but they're very expensive and there's other treatments, so they haven't really been used much yet. So to summarize, the diagnosis, avoid treatment if it can be avoided. If you need a rapid increase IVIG and high-dose IV steroids, could give platelets, you could give a TPO agent, you could give vincristine. Ideally, the count would be maintained greater than 30,000. You might need higher for special situations like sports. If you have somebody on a TPO agent or really on any agent, dapsone or whatever, and their count is being well maintained over time, then you can try to see if you can taper it by tapering very slowly and seeing what happens. We talked about combining an immunosuppressive and a TPO agent. You could use hormonal management, which could also mean if you need to block a period to give Depo-Provera as opposed to estrogen, because progestational agents actually improve ITP. And I should have mentioned previously use of antifibrinolytic agents, which are very good. So hopefully in the future, we'll be better able to distinguish patients, and that will allow us to give treatment up front that may even be curative, and or at least we'll know that it's effective. So thank you very much, and I apologize that I ran over.
Thank you, Dr. Basil. On behalf of the entire Indian Pediatric Hematology Oncology Society, I would thank you for taking your precious time in sharing your decades of experience in thrombocytopenia in children, and especially touching on what is not ITP, how to pick up those signs, and touching on topics which are less discussed, like the chronic fatigue, which our chronic ITP patients experience, and discussing on the indications other than the bleeding phenotype and platelet count, like lifestyle, etc. And especially like endorsing dapsone, like which is commonly used in our part of the country. Thank you, Dr. Basil. Again, I will hand over to Dr. Manas.
Thank you, Dr. Basil. And it was such a great moment for all of us to have you here with us with the Pediatric Hematology Oncology Chapter of India, and to listen you about speaking about ITP. So once again, thanks a lot. And just for our audience, our next topic would be after 2 weeks, which we are going to most likely cover. Is going to be on thrombosis, and we will get back to you very soon about that. Thank you. Thanks a lot.
Thank you all very much. And I, again, have always appreciated how knowledgeable you all are. And I hope you felt that was reflected in my comments.
Thank you so much. Thanks a lot.
Bye.
Bye.